Hello, hello, and welcome to the Dr. Tumor Talk Show on Tuesday. Say that fast 10 times. Um, hello, I'm Dr. Catherine Tumor. For those of you who are tuning in for the first time, I'm going to introduce myself, and you have to forgive me. I'm getting over a virus, so I'm a little bit stuffy, but I'll try to speak as clearly as possible. So again, I'm Dr. Catherine Toomer. I am a family medicine and community health physician. I'm also a metabolic weight care specialist, and I am the founder of Your Light Wellness and Weight Care Physician Group, which is a group of physicians that cater to the whole of the United States. We're a telemedicine weight care practice to give people access and acceptance, as well as, and we also work on advocacy to make sure that people get access to the medications that they need. And so if you can just say hi, tell me where you're listening from now. And if you're listening later, put hashtag replay and let me know where you're listening from later. Hello, Kim. Hello, Marcia. Thank you for coming. Um, and so today's topic is something that actually came out of last week that I got a lot of questions about. So I decided to talk about a little bit more and to add to it some. And so I wanted to talk about, of course, as a weight management specialist, I do a lot about weight loss, but because I focus mostly on the metabolic causes of weight gain, which is really very common, the most common cause of weight gain, um, and how much hormones play into that, but also how much hormones play into the psychology of sexual behavior and sexual enjoyment and desire, as well as weight kind of plays. They all sort of play in together. And so I thought it was really important to sort of tie them in together and let people know and understand how. And so that also we can talk about this a little bit more. Um, because as long as we're not talking about it, that means no one's doing anything about it. And if no one's doing anything about it, that means people are suffering in silence. And so first I'm going to talk about is weight. What exactly is weight? Now we talk about weight gain, weight loss, when really it's fat gain and fat loss. There is good weight loss. I mean, good weight loss and there's good weight gain. For example, if you're dehydrated and you drink lots of water and you step on a scale, your weight is on that scale is going to go up. If you start building muscle, the number on that scale is going to go up. If you're pregnant, that scale is going to go up. If you're underweight and you're now getting healthy, that number is going to go up. So there are lots of different reasons why weight gain is actually good. So it's really not about weight necessarily, it's about fat. We know that fat is destructive in our body. It puts out chemicals that act like hormones. It puts out actual hormones. It puts out things that make our body get inflamed. It causes problems with our small vessels in our brain, in our heart, in our kidneys, in our eyes. And so we know that fat is destructive in our body. And so there's a certain percentage that we need to have that's a healthy amount, but anything more than that, we need to lose. So therefore, you can be thin and still have too much fat in your body for health. So that's why weight is not a really good measure of health, but rather our fat percentage. And the other that I talked about before about how what is a good health measurement is our waist circumference, the ratio between our waist and our hips. And so, when that is when the ratio is too high, for men it's 1, for women it's 1.8. If we have a waist that's too much larger than our hip circumference, that's also an indication of poor health, no matter what your size. And so that's why when I talk about weight, I'm really talking about fat. And when we understand that fat production in our body is a metabolic process, meaning that there are certain things that play into our fat production. And mainly what that is our carbohydrates being broken down and not being metabolized or used properly. And when they're broken down and not metabolized or used properly, our brain doesn't get the signal it needs. It miss signals to the body and tells the body, instead of making fuel for your muscles, make fat. Instead of not eating, sending a message saying you've eaten and you're fine and you have enough nutrients, instead it tells the message to the rest of you to keep eating. It drives up your appetite. And so it's really important to understand it's not about calories in and calories out. You can take two of the exact same people, I mean, two people in the exact same family, feed them the exact same meals, and yet their body reacts differently to the food. And mainly it's because of their genetic makeup. And even if you're in the same family, you can have a different genetic makeup that you get some genes from your mom, some genes from your dad. And so it's a reason why um, it's not about calories in, calories out. So it's metabolic, carbohydrate mismanagement in our bodies. Now, our carbohydrate mismanagement in our bodies is directly tied to our hormones of insulin and cortisol. Those are the two that kind of have the most impact on how carbohydrates are metabolized in our body and therefore have the biggest impact on how much fat is made in our body. Now, the problem is that as we get older, or for whatever reason, for men and for women, as our estrogen drops, our progesterone drops, and our testosterone drops, what that does is it leaves our cortisol unopposed. And when our cortisol is unopposed, it's one of those hormones that tells our body, make fat. And so, therefore, as we go through menopause, as we go through anything that affects our metabolic status, so polycystic ovary syndrome is one, low muscle mass is another, drop in estrogen, progesterone, and testosterone, whether you're a man or a woman, that's another. Pregnancy. It's the reason we check for diabetes in pregnancy. Pregnancy causes metabolic issues. Sometimes those genes get turned on during pregnancy and they never get turned off. So any woman who's had diabetes or near diabetes in pregnancy has a higher percentage chance of becoming a diabetic later. But the problem is during the times before you become what is considered textbook diabetes, your body is already getting primed and very, very efficient in making fat. So that is the hormonal part. The problem, though, that we run into when it comes to our sexual behavior and our sexual enjoyment and desire is that as those hormones drop, our estrogen, our progesterone, and our testosterone, we lose the desire to have sex. And when you're in a relationship with someone who hasn't lost that desire, it can cause problems for a couple of reasons. One, as your weight starts to go up, we start having body image issues. As we know, some often that sexual desire and sexual enjoyment is really a psychological mechanism more than a physical. And so if you start not feeling good about yourself, if your self-esteem is being affected by your weight, or what we call weight, which is our fat production, then that does interfere with our relationships. But what also happens is as our hormones start to drop, it starts changing again desire, our libido, but it also changes enjoyment in that for men, it means that they have difficulty either getting erections or maintaining erections. And for women, what it does is it thins the lining of our vagina. And what that does makes sex very painful. And so the only way to counter that is with hormone replacement. For women, we have topical, which basically you can use vaginal hormone replacement or systemic hormone replacement. And that it really just depends on a conversation with your gynecologist, your primary care doctor, and your family history. But that's a conversation you should have. It should not be something you suffer through. And it's not just normal. It's normal. It happens. That it happens is normal. That you have to suffer through it is not normal. So again, weight is not the issue. It's our fat production and what our fat does in our body. That fat production is highly affected by our hormones, cortisol and insulin. Our cortisol is highly impacted by our hormones, estrogen, testosterone, and progesterone, and our sexual desire, sexual maintenance, sexual enjoyment is all affected by estrogen, progesterone, and testosterone. And so they're all tied together psychologically, physiologically, and socially. And so that's why it's so important to have these conversations with your doctor and to ask the questions and not suffer in silence. It is, like I said, it may be a normal physiologic change in your body, but suffering through it is not normal and you shouldn't have to. And so I see that there's some questions and I'm going to scroll up and see if I can catch them. Um, we have I have a question says, is it my imagination or do women gain weight in unusual places after menopause? Places like the back, the neck, and the thighs. Actually, the most common place for women to gain weight after menopause is their stomach because you get what's called visceral fat lay down. And basically what that is because cortisol becomes the driving force in our fat production. And when our cortisol becomes the driving force in our fat production, it starts in our middle. Now, if you already have some type of adrenal issue, which is where our cortisol is created, you can get some on your back um, and neck, like basically it's called a buffalo hump. It's right here, and you can get for your thighs as well. But primarily, it's your stomach, and that's why weight gain, or as we call, or fat production, is the only reason we pay attention to it. It's not. It's only because of the effect it has on your health. Otherwise, it wouldn't matter. It's just more just acceptance. But if it's affecting your health, obviously we need to do something about it. Marcia said, I had a hysterectomy and I've noticed that I make fat just around the lower abdomen and it's so hard to move no matter how hard I try. Does that have enough estrogen in the body causes? Yes, not having enough estrogen is what causes it. Unfortunately, once it's happened, taking estrogen does not reverse it. The only thing that reverses the fat production is a metabolic correction, and that's where GLP-1s come in or building muscle come in. Now, when it comes to building muscle, because your testosterone drops, it makes it very hard. And so sometimes hormone replacement in the form of testosterone is also important in order just to build muscle to counter that if you don't want to be on any other medication. The other benefit of testosterone in men and women is that it improves um, libido and it improves sexual enjoyment. Now, when women, though, having testosterone increasing libido isn't enough, we also have to protect the epithelial lining or the lining of our vagina as well, because when it becomes thin, it becomes also painful. And also, it puts you at higher risk for urinary tract infections, which can be dangerous also, because a bladder infection becomes a kidney infection, which can become sepsis. So it's not something to be taken lightly. And so, like, again, these are all conversations you should be having with your primary care doctor. And if it's not something your primary care doctor is comfortable talking about, then talk to your gynecologist or your urologist. If you're a man or woman, urologists should be pretty well versed in this as well. Any other questions? Well, I did offer to have people send me questions anonymously through my emails if they didn't want to do them publicly. So I have a couple here. And one of the questions was, although is how do you lower your cortisol? Actually, that's not that's not a bad question. So you lower your cortisol by essentially stress relief. You have to have daily dedicated time spent lowering your cortisol through meditation, through um, mindfulness, through gratitude journaling, deep yoga breathing. Pilates is a really good option. It lowers your cortisol and builds your muscle at the same time. But it really takes practice and it takes intention. And there are a lot of YouTube videos on how to do this. And there's also lots of different instructions. And the more you do it, the better you get at it. And also, the more quickly your body responds when you start. So Yes, there is a way to lower your cortisol. Now, when your cortisol's high, inappropriately high, there are very specific body changes that happen that tell doctors that there's something high. Many of us are walking around with high cortisol, but we don't have it to the point where it's considered pathologic, where you have to actually treat it. That is a very rare condition and it is very obvious, and we can test for it, but for the most part, we don't test for cortisol unless there's a reason to think that you have some adrenal issue going on. What about fibroids? Fibroids are, there's a combination of things. Again, fibroids is a thing where genetics meets lifestyle. And but more often, the most common thing is that you find them in families. Um, most women who have fibroids have family members who also have fibroids, and it's because their genetics are very sensitive to certain conditions that make them have fibroids. But fibroids in and of themselves can cause issues with, conception. It can affect fertility, but and depending on their size, they can actually cause some problems. The other is depending on their size and how long they've been there, the center can become cancerous. And so it really just depends on how much it's affecting your daily life. And that's again is a conversation you'd have with your gynecologist and your family or your family physician, um, and also depending on your imaging, because you can measure the size of fibroids and then decide from there which what's the best path to go. Hello from Georgia. Yes, we got a lot people from Georgia, someone from Barbados, Ohio. Well, thank you for joining. If you have any other questions, now's the time to ask before I turn off. There is one other. I have a question here. Once sex becomes painful, can that be stopped? Yes. Yes. So, um, really, however, the closer to menopause that you do something, the easier and faster it is to reverse it. There are lubricants which can help, but that only helps with lubrication. It does not change the epithelial lining. It does not change how thin it can be. It does not remove the risk of urinary tract infections. Um, and so, that's one. But the other is using hormone replacement. If you're not comfortable taking pills or using patches, then you can use what are considered topical. Unfortunately, um, the the estrogen, some of the estrogen that we can use vaginally is covered by insurance. Some of it is not, and it's just a matter of figuring out which one of your insurance, which one your insurance covers. But it may take some time. The longer you're away from menopause, the longer it takes to reverse it. And so this is something you can actually start thinking about and talking to your doctors about before you hit menopause. That's really the best time, what's called perimenopause. Before you actually stop having your periods, that is the best time to start doing something about it. It is much easier to prevent than it is to reverse. But that's across the board in medicine. Prevention is much easier than reversal. So, um, any other questions? Hello from Pennsylvania. Hi. Um, and it can be any question. It doesn't have to be necessarily about this topic, but anything weight related, hormonal related, sexual health related. Um, do if do you if the URO vaginal probiotics are a good choice? Um, there's not necessary. The our vaginal flora, as it's called, the bacteria and yeast and everything that's in our vagina, is actually natural one, and our body does it on its own. There's no need to take probiotics, and especially not insert any type of bacteria of any kind. Now, if you take probiotics orally for your gut um, health. Now that is different. But as far as, vaginal probiotics, not necessarily. Our vagina really is it's a self-cleaning organ. It is really functions quite well without any interference. The only thing that we start noticing an issue is with menopause. Other than that, and the only reason that's even necessary to even address is only because it can cause urinary tract infections and it can interfere with sexual enjoyment. Other than that, if it weren't for those things, we could just let it be. But, we're humans, we're social, and there's no reason why as we get older we should enjoy sex or want sex less and less. So that's why. Um Camille says good night. So I hope that answers your question. Any others? I only got two questions interesting in email. I thought I was going to get more. Um, was on HRT. It seemed to make my breast grow. Can the breast be reversed outside of having surgery done on them? Not usually. Now, if your breasts are sensitive to hormones, depending on, I'm assuming that it was estrogen and progesterone, it could be that, and it also depends on when you were put on hormones. So if it was, birth control type hormones, when it was perimenopause, or was it, you know, estrogen and testosterone and progesterone later, yes, you can feel some breast um, effects. But generally, when your breasts are very sensitive to hormones in that way, it's really, really important to get imaging on a regular basis. So get your mammograms to make sure, because there are some types of breast cancer that are sensitive to hormones. Um, but usually not to the point where, you know, your breast changed significantly. Um, Not usually. It's not very common. Let me just put it that way. Denise said, is it best to stay on a GLP-1 while in perimenopause? Doctors are recommending birth control versus HRT. They believe I should stay on it until menopause happens. Now, birth control versus HRT really does depend on a doctor preference, on you, and what your doctors know about you. However, GLP-1s absolutely should stay on it through perimenopause. It prevents the weight gain of menopause. It prevents the metabolic weight gain that happens as our estrogen drops and our cortisol becomes unopposed. So yes, GLP-1. I personally feel that in about 10 years, low dose GLP-1 plus HRT is going to be standard of care for women in menopause, because the issues we run into in menopause, the problems we have with dementia, with heart disease, with kidney disease, with visual changes, are all related to metabolic issues. And the only thing we have right now that blocks that metabolic problem are GLP-1s. So they're very protective in menopause and perimenopause, whether overweight or not, whether gaining weight or not, they're just protective. And I personally, um, I have relied on GLP-1 for my menopausal women quite significantly. How do you stop frequent urgent feeling only for a small amount of urine? So basically, first you need to make sure that you don't have a urinary tract infection. The second is, if you've had children vaginally, you could have some prolapse. So therefore, it gives you the sensation of needing to go to the bathroom when you don't. And then the other is if you have thinning vaginal lining, and so you do get this sense of urgency, and so using vaginal um, hormone replacement is an option. But the other is also make sure that you don't have what's called spastic bladder. So really, seeing a urologist might be a good idea if you can, to figure out why, because there's lots of different reasons why that can be the case, and it would need to be worked up. Right now, I would just be speculating, but if you have someone who can go through a history and really, do some testing, then you'll get your answer. Okay. Well, if there are no other questions, you can send me emails at help at drtumor.com. That's Dr. DRTOOMER.com. If you think of something later, and I will respond. The other thing that you can do is go to my YouTube channel, which is youtube.com/doc at Dr. Tumor, and you can ask me questions underneath the video as well. And I do watch for those. Get the notifications, and I answer those questions. So those are the best two ways of getting in touch with me. The other is you can follow me on Facebook. I do post quite a bit on all sorts of topics on Facebook as well. So you can always follow me there. So, all right. Well, thank you for coming, and I will see you next Tuesday for Dr. Tumor Talks. Oops. Oh, something didn't work there. Hold on.